Now I am honored to introduce my dear professor, Dr. Mohamed Seleem, the professor of cardiology, National Heart Institute. He will talk with us about the seasonal variation in the blood pressure. How should it be considered in clinical practice? تفضل.
Thank you, Mr. Chairman. الحقيقة برحب بحضراتكم مرة تانية وترحيب خاص بالأستاذ دكتور أحمد عماد ميديكال ميليتري أكاديمي، الأستاذ دكتور أحمد فرغالي ابن معهد القلب ورئيس المؤسسة العلاجية، وبرحب بالدكتور أحمد عادل من القصر العيني، وأهلا وسهلا بكم. My talk is about a very debatable subject and very ill-defined subject in hypertension, what's called seasonal variation. Seasonal variation of blood pressure is a topic that has gained more attention throughout the past 10 years. And although it is extensively documented that blood pressure increases in seasons coupled with lower temperature generally, in winter mainly, there are still many gaps in this knowledge field that need to be explored and studied. Notably, seasonal variation of blood pressure phenotypes such as masked and white coat hypertension and the impact of pollution, environmental factors, altitude, latitude on seasonal variation of blood pressure are still poorly described in the literature, and the levels of the existing evidence still is very low. Therefore, further investigations on these topics are needed to provide robust evidence that can be used in clinical practice. Very interestingly, this is, of course, Hippocrates, who suggested 400 years before Christianity that to investigate the medicine properly, and physicians should, in the first place, to consider the seasons of the year, which will affect many diseases, and what effects each of them produces. Blood pressure exhibits seasonal variation with lower levels at higher environmental temperature and higher at lower temperature. This is a global phenomenon affecting both sexes, all age groups, normotensive individuals even, and hypertensive patients, of course. And in treated hypertensive patients, it may result in excessive decline of the blood pressure in summer or a rise in winter, possibly deserving treatment modifications or changes. Actually, we can look in a pragmatic way to seasonal variation. It is should be viewed as a type of blood pressure variability. We have blood pressure variability, many types: beat to beat, intraday across the 24 hours, day to day, visit to visit, and even, of course, seasonal, between different months, between summer, winter, and so on. And each one of these variability is governed or affected by some factors. Seasonal variation itself mainly governed by environmental exposure to heat or changes in the temperature, and also sometimes in the geographic area. The standardization for room temperature is very important and largely removed even the effect of the season on blood pressure in what's called UK Heart Disease Prevention Project. But it can neutralize the effect of season just for diagnosis. You can keep the patient and measure the blood pressure in a standard temperature, not exceeding in the recommendation 18 degrees centigrade. However, when this patient go outside and exposed to cold, exposed to heat in his daily life, this will impact his blood pressure. Therefore, guidelines consistently recommend the importance of standardized room temperature in hypertensive clinics for accurate measurement and diagnosis of hypertension. However, also when blood pressure measurements are made in a comfortable warm rooms, a negative relationship between outdoor temperature and blood pressure values was observed. And also, well known that incidence of cardiovascular disease increase in winter. This is, all of us know that, especially the incidence of acute coronary syndrome and MI. And seasonal variation of blood pressure is considered as one of the factors for seasonal difference in cardiovascular incidence, with the same temporal relation between the rhythm of increased cardiovascular disease in winter. However, the nighttime blood pressure, especially evaluated by ambulatory blood pressure monitoring, was paradoxically higher in summer than in winter. What's the mechanism and the pathological significance of seasonal variation of blood pressure, and what's the difference between the daytime blood pressure and the nighttime between summer and winter? The time phase in which blood pressure increases and cardiovascular disease, as I have just said, develops in the same temporal relation. Nighttime blood pressure is higher in summer than that in winter, which may be associated with the development of cardiovascular disease in nighttime in summer rather than in winter. And the correlation between the nighttime blood pressure especially and target organ damage, just like the urinary albumin to creatinine ratio, was stronger in summer than in winter. And so seasonal adaptation of antihypertensive drugs, although it is not specifically considered in hypertension guidelines because treatment targets are defined only by the blood pressure values. However, in the daily clinical practice, physicians are often faced with the effect of warm temperature, which may cause blood pressure to reduce during summer with the potential implications or frequent falls or renal problems, especially, of course, in the elderly. When we come to a closer look, we will see here in summer and winter, we will start by the daytime blood pressure. We will see that during summer, generally, the daytime blood pressure is less. And in winter, it is higher than the nighttime. The vice versa for the nighttime blood pressure. In summer, it is high by night, blood pressure is high by night, and it is less by winter. So elevated nighttime blood pressure in summer, and also more patients became non-dipping during summer. Nighttime onset of cardiovascular disease events are more often in summer than in winter, and there are some explanations for this lower blood pressure in the daytime in summer compared to the nighttime, like dehydration, sweating, increased physical activity, fluid and salt intake more increased in summer, and poor sleep quality generally. In winter, the nighttime is less, and only the morning surge of the blood pressure will play a very important role in winter only. So this is the classic presentation of patients in these early hours with sympathetic surge, and the patient got a complete sleep all the night and became awakened only by this early surge of rise of the blood pressure. And also by cold weather, vasoconstriction, shivering to aiming at increasing the basal metabolic rate. Also platelet activation is more common in winter. Depression generally is more in winter, making blood pressure by the daytime. During awakening hours, blood pressure is rising, and also the incidence of airway obstruction and chest infections. The nighttime ambulatory systolic blood pressure is about 2 millimeter mercury higher in summer than in winter. And in mechanical standpoint, elevation of this nighttime blood pressure in summer may be due to short sleep duration in hot weather, heat-induced changes or perturbations in sleep, and nocturia. Increasing fluid and salt intake aimed to prevent dehydration in summer may also contribute to increasing nighttime blood pressure. And in addition, physicians often taper or decreasing the doses of antihypertensive medications due to decreased daytime blood pressure in summer, which could contribute to the elevation by night time of blood pressure. And also these changes and rise of the blood pressure, seasonal changes, is more pronounced in the elderly. This graph depicts that above age of 65, the seasonal variation is more than younger patients less than 50 years of age. Of course, Professor Karim Saeed gave us a very important lecture about the masked hypertension and white coat hypertension, and seasonal variation in these two phenotypes of hypertension is very important. And because both office and out of office blood pressure increase in colder seasons, the prevalence of sustained hypertension is markedly greater in the winter when compared to summer. Conversely, little is known regarding the impact of seasons on masked and white coat hypertension. In a very interesting Japanese study called J-HOPE on very big number of patients, more than 4,000, they found that masked hypertension prevalence was lower in summer compared to other seasons, and this has been confirmed by another study also which showed the same. However, by contrast, another Chinese study evaluating around 600 patients, however, the age group here is different, mainly adolescents, assessed by ambulatory blood pressure monitoring, reported that both white coat and masked hypertension were more frequently detected in summer. And furthermore, other investigators found a higher prevalence of nocturnal masked hypertension in summer among more than 2,000 patients, Japanese individuals assessed by home blood pressure monitoring. The discrepancies here regarding the seasonal variation of hypertension phenotypes, masked and white coat hypertension, reported by the aforementioned studies underscore raising the importance and the need of further studies addressing this topic, which is not clear in literature. The recommendation for the management of hypertension with consideration for seasonal variation in blood pressure, this is a statement by the working group of hypertension of the European Society of Cardiology. They recommend that using home blood pressure monitoring to evaluate seasonal changes in the blood pressure, and out of office monitoring of the blood pressure, whether home or ambulatory, is recommended for the diagnosis and management of hypertension. Home blood pressure monitoring may be useful for the evaluation of seasonal variation with optimum adjustment of antihypertensive medications. And also, we have to start to adjust our medicine early in the season. For example, for increasing blood pressure in winter, adjustment of drugs should be carried on or conducted in September and November instead of during winter itself in December and February, and in summer we have to start adjustment by early summer in March and May instead of June and August. And when blood pressure decreases in summer, even if the patient is asymptomatic around the range of less than 110, 120, whether office, home or daytime ambulatory, especially in elderly, it should be carefully considered for starting tapering or decreasing the doses of antihypertensive medications. And we have to optimize also the environmental factors, because some patients showed a very great seasonal variation and others not. So we have to optimize these environmental factors. And the WHO guidelines recommend that optimum room temperature not more than 18 degrees centigrade in winter and during measurement of blood pressure. Also, individual patient conditions such as age, sex should be considered when determining the optimum room temperature for winter, and this has been raised in perimenopausal women. They are sensitive a little bit to change in temperature and showing increasing or decreasing blood pressure in response to changing of temperature. And finally, using ICT-based medicine. ICT is the information and communication technology with the use of artificial intelligence, and the use of home blood pressure device equipped with ICT system may be useful to prevent larger seasonal variations of blood pressure, such as excessive rise in winter or excessive decline in summer. My final slides to reach conclusion. The control for concurrent environmental changes is to be considered in both clinical practice and research studies, still underrepresented in the guidelines so far. In the daily clinical practice, ambulatory blood pressure monitoring is important in monitoring the antihypertensive treatment under conditions of unstable or often extreme temperature exposures. Short-term temperature changes mainly affect blood pressure during daytime, whereas seasonally mainly affect nighttime systolic blood pressure, especially in summer. Population surveys in general should routinely consider the seasonal variation in blood pressure, and epidemiological surveys aimed at estimating hypertension burden in a community may include environmental temperature measured indoor as variable, potentially affecting results rather than considering outdoor temperature only. And finally, awareness of this phenomenon will result in more personalized, individualized, tailored dosages of antihypertensive medications. And thank you.
Many thanks, Dr. Mohamed, for this elegant presentation. Any question from the floor? Okay, thank you.
شكرا جزيلا. شكرا.